Welcome to The Deep Dive. Today, we're plunging into, well, a really fascinating set of sources. They highlight just how complex and interconnected our bodies are.
Absolutely.
Our mission to pull out the key insights, the nuggets of knowledge to help you understand conditions, meds, treatments, focusing on two vital systems, kidneys and eyes, often linked, right?
Yeah, definitely linked. And what's fascinating here, I think, is how systems you might think are totally separate are actually, intimately connected.
Right.
These sources really show that. They give us a window into how these critical balances are kept, or sometimes how they're lost.
Okay, let's unpack this journey into the kidneys then. Master filters, we call them. But they do so much more. Understanding them is, well, key to overall health.
Totally.
Our sources bring up some key terms. I think starting there helps frame it all. First step, glomerular filtration rate, GFR.
Right, GFR. Think of it like a speedometer for your kidneys. Tells you how fast they're cleaning your blood, basically.
Okay, speedometer, so higher is generally better.
Yeah, it usually means they're working efficiently.
And when that speedometer drops,
That's when we start seeing signs of trouble. If urine output drops significantly, say less than about half a milliliter per kilogram per hour, we call that oliguria.
oliguria, okay. Oh, warning sign.
A critical warning sign, yeah.
Yeah.
Kidneys are struggling. And if it drops even further, like almost no urine output, less than 10 mils an hour, that's anuria.
Anuria, and that's an emergency.
Definitely a medical emergency.
So those are the signals, but what's actually happening inside the body when the filtering slows down like that?
Good question. That's when we might see azotemia. Basically, waste products, BUN, creatinine, uric acid, they start building up in the blood because they're not getting filtered out.
Okay, azotemia. Buildup.
And if that buildup gets worse and you start seeing actual symptoms,
Mhm.
like high potassium, swelling, maybe anemia, that's a more severe stage called uremia.
Uremia.
Yeah, and our sources describe it pretty well as urine in the blood because those toxins are just circulating. Not good.
Not good at all. Okay, basics covered. Now, how do these filters actually get into trouble? What are some common conditions the sources highlight?
Well, connecting this to the bigger picture, a lot of kidney problems come down to inflammation, infection, or just long-term damage. Let's take glomerulonephritis.
Okay.
What's really insightful here is how something common, like, say, a recent strep throat, can actually trigger your own immune system to attack the kidney filters.
Wow, so your body attacks itself.
Kind of, yeah.
Yeah.
It's a powerful reminder of how connected everything is. This inflammation makes these big molecules clog the kidneys.
Clogging the filters.
Right, which leads to water retention. You get blood and protein in the urine. That's hematuria and proteinuria.
Okay.
Swelling, especially in the face, high blood pressure, feeling really tired,
Yeah.
lethargic. Treatment involves steroids for the inflammation, maybe antibiotics if there's still an infection, and managing that fluid overload carefully, often trying not to jump straight to diuretics if possible.
Sounds complex, especially if it hits kids often. But what about a more direct attack, like an actual infection getting in the kidneys?
Ah, right. That's pyelonephritis, an
Yeah.
actual kidney infection.
Mhm.
Most often it happens when a UTI, the urinary tract infection, travels upwards.
So it climbs up.
Exactly. Imagine bacteria invading these delicate organs.
Hmm.
You'll see symptoms like fever, fast heart rate, really bad flank pain, nausea,
Ouch.
yeah, and cloudy, maybe foul-smelling urine. If you don't treat it properly, it can lead to serious long-term damage, even end-stage renal disease down the line.
That sounds serious, but preventable sometimes.
Yes, and the sources emphasize this. Simple things. Drinking enough fluids, good hygiene, voiding after intercourse, avoiding things like bubble baths, wearing cotton underwear makes a difference.
Okay, so glomerulonephritis is immune, pyelonephritis is infection. What about just wear and tear over time?
Good point. That brings us to things like nephrosclerosis. Essentially, it's a hardening and narrowing of the arteries in the kidneys, usually driven by long-term high blood pressure.
Hypertension.
Right. And it creates this nasty cycle. The kidneys sense less blood flow, so they release more renin.
Renin, that hormone.
Yeah, which then constricts blood vessels even more, body-wide. It's a vicious loop. Lifestyle is huge here, as the sources point out. Low cholesterol, low sodium diet, keeping blood sugar controlled, stopping smoking, all crucial.
Makes sense. And there was one more, nephrotic syndrome. That sounded pretty dramatic in the notes.
It is dramatic. Imagine
Yeah.
the kidneys filters, right? Like superfine sieves.
Yeah.
Keep protein in, let water out.
Got it.
In nephrotic syndrome, it's like those sieves suddenly get huge holes. Everything starts leaking out, especially protein.
Leaking protein.
Massively. It's called massive proteinuria. So much protein leaks into the urine, it can actually make it look foamy,
Hmm.
like soap suds.
Whoa.
Yeah. Treatment focuses on managing infection risk, giving fluids and albumin to replace what's lost, sometimes using meds called vasopressors to support blood pressure.
Okay, this is fascinating, especially thinking about how kidneys can run into trouble. Our sources make a distinction, right, between sudden acute problems and the chronic long-term ones. Let's dig into acute kidney injury first, AKI. It's sudden, and it seems to have very specific phases.
Absolutely. AKI is that sudden drop in kidney function.
Okay.
And it does tend to follow a pattern, these stages. First, the initial injury stage. You might not even have symptoms yet.
Okay, so it can sneak up on you.
It can. Then comes the oliguric stage. That's where urine output plummets.
Yeah.
And this is a really critical time. You get severe electrolyte imbalances, potassium goes way up, calcium drops, fluid overload is a big issue, and the body's acid-base balance gets thrown way off, usually towards acidosis.
Sounds like a metabolic crisis.
It really is. Multiple systems are struggling hard.
Okay, so that's the low output phase. What happens next? Do they just start working again?
Well, hopefully, if they start to recover, you enter the diuresis stage. Now, the kidneys start flushing out all that excess fluid, sometimes too much, actually.
Oh, so you can swing the other way. Fluid deficit.
Exactly. And the electrolytes shift. Again, potassium might drop low, calcium might go high. The acid-base balance can swing towards alkalosis.
It's a real roller coaster.
It can be. Finally, hopefully you get to the recovery stage. This can take a while, 3 months, maybe even a year. The kidneys slowly heal, and the advice is usually, protect them, avoid any further insults.
Wow. So AKI, this sudden hit, can be devastating. But what actually causes it? The sources break it down by location, right? Before, within, or after the kidney.
Yeah, that's a really helpful way to think about it. First, you've got pre-renal causes. That's all about blood flow to the kidneys.
Not enough blood getting there.
Exactly. Think severe dehydration, major bleeding or trauma, heart failure where the pump isn't strong enough, or widespread infection, sepsis, causing low blood pressure.
So fix the underlying blood flow problem.
Pretty much. Stop the bleeding, give fluids, support the blood pressure, treat the sepsis, get blood back to the kidneys.
Makes sense. What about problems inside the kidney itself?
Those are intrarenal causes.
Yeah.
Direct damage to the kidney tissue. This could be from chronic infections, inflammation, like we talked about with glomerulonephritis.
Or medications?
Definitely. Certain meds are notoriously hard on the kidneys, nephrotoxic, some chemo drugs, certain antibiotics like the mycins, even common things like NSAIDs or ACE inhibitors in some people.
Wow.
And of course, uncontrolled high blood pressure and diabetes are major culprits for direct kidney damage over time.
So prevention is key there. Monitoring drug levels, treating the diabetes, and hypertension.
Exactly. And sometimes protecting the kidneys during procedures like contrast dye studies with extra hydration or specific meds.
Okay. Pre-renal, interrenal. What's the last category?
Postrenal. This is about blockage after the kidneys. Something stopping the urine from getting out.
Like a plumbing problem.
Good analogy. Could be kidney stones blocking the ureter, an enlarged prostate clamping the urethra shut, problems with a Foley catheter not draining, even a severe UTI causing retention.
So the fix is unblock the plumbing.
Essentially, yes. Manage the catheter, treat the stones or prostate issue, clear the obstruction.
Okay, that clarifies AKI. But then there's a long game. Chronic kidney disease, CKD, and eventually end-stage renal disease, ESRD, long-term failure. How does the body cope differently in the long run versus that acute crisis?
That's a great question. And it really highlights the kidney's role in acid-base balance using bicarbonate or HCO3.
Right, the buffer system.
Exactly.
Yeah.
In AKI, that sudden crisis, the body is often uncompensated. The pH might look normal for a second, but either the CO2 or the bicarb levels are way out of whack. The system's overwhelmed.
But in chronic disease,
In CKD, over time, the body tries to compensate. So you might still see a normal-ish pH, but both CO2 and the bicarb levels will likely be abnormal. The body's working overtime, trying to counteract the failing kidneys. Often the pH will still lean a bit towards acidosis, closer to 7.35, showing the underlying problem, but the compensation buffers it somewhat.
fascinating. It's like the body learns to live with the problem, even if imperfectly.
It's trying its best. But that constant strain takes a toll.
It really sounds like a constant balancing act. Which brings us to management. How do we manage these complex conditions, especially things like fluid and electrolytes going haywire? Let's start with fluid overload, FVO.
Right, FVO, it can be really dangerous. Signs. Well, heart rate goes up, blood pressure often up, breathing gets fast and shallow, oxygen levels drop.
Lungs filling up.
Yeah, you might hear crackles, sometimes even pink, frothy sputum. Skiing can get really stretched, even wheat fluid. Obvious weight gain, swelling everywhere, what we call anasarca. Fluid can collect in the belly ascites. And it can even affect the brain, causing confusion due to cerebral edema.
That sounds awful, but can be done.
First steps are usually restricting fluids and cutting way back on sodium. Remember, where sodium goes, water follows.
Makes sense.
Then diuretics are key. Loop diuretics like furosemide Lasix are often the first choice, especially in severe kidney disease. Very potent. But you have to time them right, not give them at bedtime usually. For more chronic FVO, sometimes potassium-sparing diuretics like spironolactone are used. But you have to watch potassium levels like a hawk.
Because they hold on to potassium.
Exactly. And then there are osmotic diuretics like mannitol, kind of a last resort before dialysis. They need careful handling, can crystallize, need warming, special filters.
Wow. Complex meds.
They are. And beyond meds, strict daily weights, measuring every drop in and out, frequent neurochecks, vitals, heart monitoring. It's intensive. Sometimes giving albumin can help pull fluid back into the blood vessels to make the diuretics or dialysis work better.
Okay, fluids handled. What about electrolytes? High potassium, hyperkalemia sounded particularly scary because of the heart.
It is the most immediately life-threatening electrolyte imbalance, typically, because of the heart.
What are the signs?
Critically, those cardiac dysrhythmias. You see changes on the EKG-wide QRS, peak T waves. The heart rhythm can go crazy, fast or slow, even into VTach or AFib. Patients might also feel weak, tired, confused, get tingling or numbness, paresthesia.
So how do you fix that, especially in an emergency?
Priority 1, stabilize the heart. Priority 2, get rid of the potassium. First, stop any potassium intake that includes salt substitutes. They're often potassium chloride.
Good tip.
For quick action, IV insulin, regular insulin, along with dextrose, pushes potassium out of the blood and into the cells. Temporarily buys time.
Okay, shifted inside.
And calcium gluconate, the fourth. This doesn't lower potassium, but it protects the heart muscle, calms it down, prevents those deadly rhythms. Absolutely vital.
Protect the heart first. Makes sense. Then get rid of it.
Yeah. Longer-term removal involves meds that bind potassium in the gut. The older one is Kayexalate, a resin. Works, but slower, can cause GI issues. Newer binders like Potiramir are often used for chronic hyperkalemia, maybe safer, but still have some GI side effects and drug interactions. And obviously stop any potassium-sparing diuretics and keep them on a heart monitor.
Got it. And you mentioned calcium and phosphorus often go together when kidneys fail. Low calcium, high phosphorus.
That's the typical pattern, yeah. Hypocalcemia and hyperphosphatemia. Early signs of low calcium can be subtle muscle twitching, tingling, cramps, that tetany.
Tetany.
You might see those specific signs. Schwarzkopf's tapping the cheek causes a facial twitch, or Trousseau's inflating a blood pressure cuff causes the hand to spasm. More severe signs include dangerous heart rhythms. Remember, calcium calms the heart, and also weak bones, fractures, bone pain.
Because the body's pulling calcium from the bones.
Exactly. So interventions. Avoid high phosphorus foods, dark sodas, processed stuff. Fall precautions are important due to weak bones. Give vitamin D, often the activated form calcitriol, because failing kidneys can't activate it and you need it to absorb calcium.
Okay.
And phosphate binders, meds like sevelamer calcium acetate. You take these with meals to bind the phosphorus in the food so it doesn't get absorbed.
Bind it in the gut.
Right. And for low calcium itself, oral calcium supplements like calcium carbonate, or as severe, IV calcium gluconate or calcium chloride. But 4V calcium needs extreme care. It's a vesicant, can damage veins, needs slow infusion, good IV access, preferably a central line.
Lots to manage. Beyond fluids and electrolytes, what other key meds did the sources highlight for kidney patients, especially for chronic issues?
Well, anemia is super common in CKD because damaged kidneys don't make enough erythropoietin, or EPO, the hormone that tells your bone marrow to make red blood cells.
So that's why they get anemic.
Exactly. So we give epoetin alpha, brand names Epogen, Procrit. It's synthetic EPO, stimulates red cell production. But you have to monitor blood pressure and hemoglobin carefully. Too high a rise increases risk of clots, stroke, hypertension.
Tricky balance. What else?
We mentioned calcitriol already, the activated vitamin D, crucial for calcium-phosphorus balance. And sometimes corticosteroids like prednisone are used.
For inflammation.
Yeah, for immune-related kidney diseases like glomerulonephritis, or to prevent rejection after a kidney transplant. They suppress the immune system or reduce inflammation, but come with risks like infection, fluid shifts, blood sugar issues. Need careful management.
And meds to protect the kidneys themselves.
Sometimes, Acetylcysteine, or Mucomyst, is sometimes given before contrast dye procedures to try and prevent contrast-induced kidney injury. And sodium bicarbonate can be used to treat the metabolic acidosis of CKD, or sometimes like insulin, to temporarily shift potassium in an emergency.
Okay. And when all these meds and management strategies aren't enough, or for complete failure, that's dialysis.
That's dialysis, a life-sustaining treatment that mimics what the kidneys do.
How does it work? The main type is hemodialysis.
Yeah, hemodialysis is the most common, maybe 90% of patients.
Yeah.
Typically done in a center 3 times a week for about 3-4 hours each time. Your blood is pulled out, run through a special filter called a dialyzer. That's the artificial kidney with semi-permeable membranes and cleaned. Waste products are removed, electrolytes are balanced using a special fluid called dialysate on the other side of the membrane, and the clean blood is returned to you.
How do they get the blood in and out?
Requires special access, could be a temporary catheter like a Vascath, a more long-term tunneled one like a Permacath, or ideally a permanent surgical access like an AV graft, which uses synthetic material, or the gold standard, an AV fistula, where they surgically connect an artery and a vein in your arm.
Fistula, heard of that.
Yeah, it creates a strong vessel that can handle the rapid blood flow needed for dialysis, sometimes up to 400 milliliters per minute.
Wow, that's fast. But there's another type, right? Something people can do at home. Peritoneal dialysis.
Yes, PD.
Yeah.
It's quite different. A soft catheter, called a Tenkhoff catheter, is surgically placed into the peritoneal cavity, the space in your abdomen. Then, you instill sterile dialysis fluid into that cavity. Your own peritoneal membrane, the lining of your abdomen, acts as the natural filter. Waste products and excess fluid pass from your blood vessels into the dialysis fluid, which you then drain out and replace.
So your own body is the filter.
In a way, yes.
Hmm.
The membrane is. It's usually done multiple times a day, maybe 5-6 exchanges, often done at home, which gives people more freedom, fewer dietary restrictions usually compared to hemo.
Feels great. Downsides.
The main risk is infection, peritonitis, infection inside the abdomen. That's serious. Also, some people struggle with body image having the catheter, and the control over fluid and electrolytes isn't quite as precise as with hemodialysis.
Trade-offs, like always. And for the really sick patients in the ICU.
Right. For critically ill, unstable patients, there's CRT, continuous renal replacement therapy. Think of it as 247 hemodialysis, but run very slowly and gently.
Low and slow.
Exactly. Continuous filtering to manage fluids and electrolytes without stressing their already unstable system.
Incredible technology. Okay, we've gone deep on kidneys. But the source has also touched on eye health. Seems like a totally different system, but we saw links, like with diabetes.
Exactly. That interconnectedness again. It's amazing how many systemic diseases show up in the eyes. And eye treatments can have wider effects too. Let's look at what the sources covered. Cataracts, for instance.
Right. Common, age-related.
Yeah, not usually an emergency. It's that clouding of the lens from protein buildup. Makes vision blurry, causes halos around lights, difficulty driving at night.
And the fix is surgery.
Yep, surgery to remove the cloudy lens and pop in a clear artificial one. Post-op care is key, though. Covering the eye at night, sticking to the eye drop schedule religiously, no straining or heavy lifting, no sleeping on that side.
Got it. Then there's glaucoma. That sounds more serious, related to eye pressure?
It is serious. Glaucoma is about losing peripheral vision, your side vision, because the pressure inside the eye, the intraocular pressure, or IOP, gets too high.
High pressure damages the optic nerve.
Precisely. It usually happens slowly. That's open-angle glaucoma, not an emergency. But there's also closed-angle glaucoma, which is a sudden, painful emergency needing immediate treatment to save sight.
How do you manage the pressure?
Mostly with eye drops. Beta blocker drops like Timolol are common. They reduce how much fluid the eye makes. But, and this is critical, as the sources note, they can get absorbed into the body.
Systemic effects.
Yeah. Can slow the heart rate, lower blood pressure, even trigger asthma attacks because of bronchospasm.
Yeah.
So not for everyone, especially people with asthma, COPD, or slow heart rates. And proper technique is vital.
Technique for eye drops.
Yes. Pressing gently on the tear duct right near the nose for about 30 seconds after putting the drop in. It's called punctal occlusion. Helps stop the med from draining into the bloodstream so quickly.
Huh. Never knew that. Other types of drops.
Prostaglandin analogs are another major class. They work differently. They increase the drainage of fluid out of the eye. Can cause some eye irritation, maybe change iris color slightly, or make eyelashes grow longer. Also need good technique. Punctal occlusion for about a minute.
Fascinating. What about conditions linked to other diseases, like diabetes again?
Right, retinopathy. Diabetic retinopathy is a big one, caused by damage to the blood vessels in the retina from uncontrolled diabetes. Sadly, it can lead to severe vision loss. Our sources say most vision is gone.
Is there treatment?
Not really for the damage done, no cure, which makes controlling the underlying diabetes absolutely essential. Adaptations help: big fonts, good light, magnifiers. It's not an emergency itself, but devastating.
And macular degeneration.
Similar story, in a way.
Yeah.
Macular degeneration is usually age-related. It affects the central part of the retina, the macula, causing loss of central vision, makes reading, recognizing faces really hard, worsens over time.
Any treatment?
No cure, but sometimes injections into the eye can slow it down. Big impact on daily life driving, safety. Patients have to learn to use their remaining peripheral vision. Protecting eyes from UV light might help prevention. Again, not an emergency, but life-changing.
But some eye things are emergencies, right?
Oh, absolutely. A detached retina is a true emergency. The retina pulls away from the back of the eye.
What causes that?
Can be an injury, like whiplash, or just happens spontaneously. Symptoms are key. Suddenly seeing lots of new floaters, bright flashes of light, or feeling like a curtain is coming across your vision. Usually painless, but needs immediate medical help to reattach it and save vision.
Okay, detached retina emergency. Anything else?
Hemianopsia. This is vision loss in one half of the visual field, like only see the right side or the left side of everything. It's caused by a stroke, damaging the visual pathways in the brain.
So it's a brain problem showing up in the eyes.
Exactly. The eye itself might be fine. It's not an eye emergency per se, but the stroke causing it obviously is. Huge impact, can't drive, need to adapt everything, learn to scan by turning your head.
Wow, so much interconnectedness. And after eye surgery, in general, what's the takeaway care?
Key things seem to be: keep the eye protected, especially at night initially.
Yeah.
Be absolutely diligent with the prescribed eye drops, timing, dosage, technique. Avoid any straining, no heavy lifting, often over 10 pounds is the limit, no bending at the waist. And using those aids magnifiers, big fonts, can really help during recovery and beyond.
Okay. We've covered a massive amount of ground: kidneys, eyes, the intricate details. What's the big takeaway? What does this all mean for us? It really paints a picture of, like, complex harmony.
It really does. And I think connecting it all, the biggest takeaway is that constant interplay. Like you said, diabetes, hypertension, stroke, they don't just hit one spot, they ripple outwards.
Ripple effect.
Yeah. Uncontrolled diabetes damages tiny vessels in the eyes, causing retinopathy, and in the kidneys, causing kidney failure, CKD. Hypertension hammers the kidney arteries, leading to nephrosclerosis, and it makes fluid overload worse, straining the heart. A stroke hits the brain, but can wipe out half your vision with hemianopsia.
So understanding these links, it's crucial.
Absolutely. For spotting symptoms early, for understanding why treatments for one thing might affect another, and just for promoting overall health. You can't really isolate one system.
And that brings our deep dive on kidney and eye health to a close. We've seen the delicate balances, the ways things can go wrong, the amazing ways we try to manage it. Hopefully, you're leaving with some real aha moments.
Yeah, and I think knowledge is powerful, right?
Yeah.
Especially when you understand why. This dive really shows how critical thinking helps navigate these connections in the body. There's always more to learn, and looking at it from different angles, different systems, really helps.
Totally agree. So here's a final thought for you, the listener, to mull over. Think about how one single lifestyle choice, maybe managing blood sugar, maybe keeping blood pressure in check, maybe even just staying hydrated, how that one thing can trigger a whole domino effect, protecting or potentially harming multiple vital organs. How does knowing about that deep interconnectedness maybe change how you think about your daily health choices? Thank you so much for joining us on this deep dive. We hope you keep exploring these fascinating connections within the amazing human body.